that we've had the opportunity to talk about together over the last few years. I don't want to harp on healthcare costs. I know you are all living here in Oregon and experiencing healthcare costs in your day-to-day life too, but I've had this question in my mind really since we ended the last renewal together in April, and we did the best that we could for our members. The renewal increase was not 3.4%, and we had to make some tough decisions. And so we always come out of those really with an opportunity to reflect on why were we in that position? And I think that's been the burning question on my mind over the summer. Why are healthcare trends so high? Why have they been so high? And when are they going to stop being so high finally for us, so we can get back to the business of looking at expanding benefits and covering some of the topics that we've had to table now for a couple of years. And so as part of that work, so many research bodies and academic bodies and even government bodies have been studying this same question. And really the consensus, and at the point of this slide, the consensus is that we are still coming out of this series of ripple effects that were caused by the pandemic. And, back in the very beginning, there was this shock to our healthcare system that was people couldn't go to the doctor for a long time. And you can remember the statistics back then, 40% of healthcare was deferred because initially it was practical. People couldn't go into offices because there were mandated closures. But then it was a little bit sentimental too, which is it safe to go in? And so screenings were put off, routine care was put off, and we all knew to ask the questions at that time, like, surely this is going to have downstream impacts on health. What are they going to be? And then the second thing happened after the pandemic, directly impacted, of course, member health. We were dealing with that also at the time. It impacted our provider workforce in really profound ways. And we already had a provider shortage in the healthcare workforce. And I'm sure Misty could talk about this in much more detail now in her new role. But because of the toll of being a healthcare provider during COVID and the stress of that environment, that accelerated the healthcare workforce shortage, and not just in medical care. Remember Dr. Barrichello coming and Kaiser also to talk to us about maybe they had 1 out of every 2 dental assistant positions was open, and it was actually the hygienist limitations that were limiting dental access at that time. It has since resolved, but we saw these access constraints all throughout our healthcare system. And people couldn't get in. And so now we have that compounding this initial issue of deferred preventive care, deferred screening. And then maybe the sentiment changed a little bit and we were ready to go in, and then we couldn't because there wasn't enough access. And then all of this work was taken underway by our carrier partners and by the healthcare workforce in general to add providers to the network. So access has been increasing, but so has the utilization. And so what we're seeing is the more appointments that we add for services, the more appointments are filled. And so we've been seeing increasing utilization every year in our OEBB data. And of course, we have unit cost trend also. We're seeing unit cost trend. Of course, we're helped some by Senate Bill 1067 on our hospital expenses, but we've been seeing unit cost trend in pharmacy and in office visits. And then we've primarily been seeing utilization trend. So more people going in for more office visits, health visits, more everything. And we're still seeing that. As what's happening, I think, is that the pent-up demand is catching up with access. And the general consensus is that will stabilize. There will be a ceiling trend. We're still experiencing it now in mid-2025. And so we have not seen trends yet begin to level out, primarily because of that utilization piece. And we talk a lot about access too. It's kind of the flip side of the access coin is the higher utilization, which leads to better health outcomes, we know, which is why we do it. But the healthcare environment right now, of course, the economy and just general inflation is increasing unit costs also with the cost of supplies and medical equipment, but we're still seeing relatively high trends. And the consensus is maybe that will start to stabilize in 2026 or 2027. But as we know about healthcare, it is so complicated. There are so many factors. Things like we work to control costs in one area, and then there's a new breakthrough therapy or a new mandated benefit or things that improve health outcomes over the long term, but raise questions for us about affordability in the meantime. So we're here with you to partner through the next renewal, and Ian is going to talk a lot about the role that cardiovascular care, so heart health, the role that heart health plays in improving outcomes for our members. And we're going to talk about health equity as well, and really focus on level setting for the upcoming renewal with some really important topics and ways that we can help our members.
Just so that I kind of understand this a little bit better. You know, we're seeing higher utilization than pre-pandemic, right? But insurance companies charge a premium, and people pay that premium to access of care, regardless of whether or not they utilize that, right? Those premiums are set. And so pre-pandemic, when utilization was low, you know, oftentimes insurance companies are receiving premiums, and that, like, I know, for example, my husband has not been to the doctor in like 10 years. So I'm paying insurance for him and he doesn't even utilize that, right? So like, and then during the pandemic, utilization was really low. So there's a lot of money flowing in and not a lot coming out. And it's just curious to me that, you know, now we're catching up with pre-pandemic, but it seems like that should have, you know, the prior low utilization and then even lower during COVID, like, and now the utilization coming up, like, should have found some middle ground and not really resulted in premiums skyrocketing as they are, right? Like, there was a lot more money coming in than utilization prior, and now it's a lot more utilization. It's really a hard pill for me to swallow, that now that people are using the insurance that they pay for, there's you know, that there's like almost a penalizing effect for utilization, and that now premiums go up because people are using the insurance at a higher rate, right? Like, that doesn't compute to me. So
yeah, you said a lot of really important things, Sally. There are lots of pieces to your answer, so let's take them from the beginning. So pre-pandemic, let's call that like normal utilization, just so that we can talk about post-pandemic.
Yeah.
So pre-pandemic, we had this balance between providers giving access and members going in for care. And it's true, some members don't use care. They use a really low amount of care. Mm-hmm. I don't know right off the percentage for medical that don't. Mm-hmm. But there definitely is some. And the way that insurance was priced before the pandemic, and even it's priced now too, the premium contains about 10% for expenses and other stuff, and 90% is the budget for paying claims. And so included in that budget, that takes into account the people who don't use any care at all. Mm-hmm. That's like the average of everybody, people who use more than their premium, and then people who use less than their premium would support. And then together it averages out to this 90%. And then after the pandemic, a couple really important things changed. So in that initial time period where the utilization really dropped off after COVID, OEBB did generate a big surplus that year. And that surplus did go and fund the RSR stabilization reserve. So it's not like that money disappeared. And we have been using that fund strategically each year during the renewal to advance clinical initiatives, sometimes to buy down the renewal increase. So in a sense, doing exactly what you're talking about. And there is more RSR balance still available. So in the future, we could So that's exactly what that was intended for. That rate stabilization reserve was to do with what you're talking about. But there are a couple things that are materially different to Sally than before the pandemic, and it's that the provider workforce has changed and the underlying inflation within the economy is different. And also there's this idea that because of that plummeting of care, that trough in care, now we have on average a higher illness burden in our population than we did before the pandemic. And health habits have changed too. So if we just think about collectively as Americans, we're a little bit more unhealthy than we were before the pandemic. So we're going to cost a little bit more to treat. So it's not exactly the same thing, but I do want to highlight that financially, the mechanics of how that money worked, we actually are doing a little bit of what you talked about. And when we come to the financial part of the discussion for the renewal, really beginning in February, we talk about round one, February, March, and April. We can talk about how to do what you're talking about and access some of that money that's still available. We always talk about the flip side of buying down the renewal.
I just, being the employee facing person, it's like hard to tell them, your premiums are going up and your, co-pays and stuff are going up when the average wage for classified employees at 4J is $35,000 a year, right? So that's who I interact with on a daily basis, and that, and I know it's more complex, and thank you for offering some more clarity. Like I said, it's just hard that, okay, you are, care was postponed and maybe you're utilizing it more because we are sicker, and I think mental health care too is utilized far greater, but, essentially because you're using that, now we're moving the affordability farther and farther out of reach for you. And then my concern, and I brought this up before, is like, the more that we do that, the more we're like doing the same, right? Like people now will put off preventative care or certain services because now it's not as affordable, and then we're going to play a catch-up game, right? So I get concerned about that.
Yeah, you expressed the concern really eloquently, Sally. I feel like, we share that concern too, and the Mercer team had a lot of angst also over the summer, especially, we had to make benefit changes, to be frank about it. Some of them were painful. Last renewal season, that's the last thing, anybody wants to do.
Robert and Ollie.
Yeah, I was just going to say, my experience for the past 7 years is that we operate year to year. And so during COVID, because there was less utilization, we had much lower than normal increases. In fact, there was 1 year where Kaiser went negative. And so I think some of that got washed out during the pandemic. So there's not an extra pile of money.
Yeah, I was just going to mention this afternoon, I'll talk a little bit about the reserves and kind of where we were pre-pandemic to where we are right now. I made a comment to Rick the other day that you see large increases. Healthcare inflation is kind of going away a little bit, but it's never been in a better financial position than it is right now with the reserves they built up. But yeah, it's getting the 3.4%.
Yeah.
Thank you guys for answering.
Very good point. And I think Dr. Lotta probably knows more about this than I do, but I'm concerned that impacts of the HR1 bill will have on healthcare, and how will that impact our budget? So maybe we can touch lightly on that at some point, because it's all tied up, like the healthcare, and we have members who are part of the SNAP system or WIC, and that's a supplemental income that helps those individuals. So I hope when we do calculations, we can implement that somehow. And I know we discussed it as a leadership team, but for the group. And then I want to apologize because I forgot to adopt the agenda with flexibility. So I can do that now. That'll be great. Unless you have any suggestions, Ali, on that.
We do what?
Adopt the agenda with flexibility.
Oh, yeah.
And I made a motion on that.
Yeah, we can do it anytime.
I need a motion to adopt the agenda with flexibility.
I will make that motion.
All right, thanks, Robert. Thank you, Bonnie. All those in favor to adopt the agenda with flexibility?
One more, we have some discussion on the agenda.
Yeah.
I may be the only one who's still a year into this, right? I still have things to learn. Can you say again what it is, the question is that's on the table?
Oh, yeah. So in board meetings, we use Robert's rules, which is not my favorite thing. And Robert's rules is the form of order that we make motions here on the board. And I'm asking to adopt the agenda that was shown on the second slide, second page, and that's the agenda we should follow for the rest of the day.
I'm with you.
Cool.
Thank you.
All right. Without objection, we adopt the agenda with flexibility. All right, cool. So instead of calling the vote, I just ask if there's no objections to adopt the agenda, so there's no objections. We're good. Thank you. And I'm just getting ready for my RA. I said, just kidding. From 700 people. All right, thank you. Go ahead.
Thanks, Enrique. And actually, before we move on, I don't think that we looked at the agenda together. There's one thing on the agenda that's relevant to what Enrique said. Rose, if you don't mind skipping back to slide 2, please, just briefly. Let's just do a super quick whirlwind tour of the day. So we had wonderful welcomes from our director and chair, and we got an opportunity to hear each other's favorite things and orientations to the board. We're right in the middle of a little bit of a kickoff, setting the stage for today. Ian is going to walk us through. Dr. Ian Chuang is our clinical physician advisor, and Sarah Drake also is our pharmacist, our pharmacy expert. And then we have Christy Ewing and Maggie Kincaid here representing Health Equity, and Rob Fauci here also is a clinical expert. And so the clinical team led by Ian is going to walk us through cost and utilization data with a health equity lens, which we talked about doing last month, and then some clinical renewal strategy. There's an item you'll notice it goes from 12:10 to 1 o'clock. What's in the middle of that? Thanks to OHA staff for arranging lunch for us. The lunch will be brought in. Also, a Mercer colleague named Wade Simons is going to join us over lunch. Wade is our regulatory advisor. He's going to lead a discussion for us on what's happening with federal legislation and potential impacts in the healthcare system. So that will be really interesting. That'll be an informal roundtable discussion that we can all participate in during lunch. And then we'll come back in the afternoon. We have a couple follow-ups from last month. So we didn't get to the dental and vision cost and utilization review. Ali has some things that he wants to share, some updates to give to the board. Sarah's going to talk about innovation as it relates to the pharmacy pipeline, also a follow-up from last month. Georgianne, a member of OHA staff, Georgianne does an amazing job bringing new entities into OEB and PEB. She's going to talk a little bit about the economics of, from the employer side, from the entity side, the economics of premium and employer health insurance funding. And then Christy and Maggie are going to circle us back to the health equity strategy, which we started. We're going to come back and finish that up and ask for an adoption of the health equity strategy. And then we have an item there called wrap up, which is essentially an extra 20 minutes for us to circle back to anything that needs some additional discussion before the end of the day. And then we'll close the afternoon and get you on your way, hopefully by 3:30.
So we are on time. That's good.
Awesome. Thanks, Rose. So we'll go ahead to slide 10 and I'll pass it off to John.
So before we dive into the retreat, we wanted to touch upon, and Chris mentioned this, some context setting slides. And this one is really just kind of helping to understand the complexity of the environment. So this is just a partial picture of all the committees that exist under the Oregon Health Authority. You can see at the top you have, OEB and you have some of the committees that, make recommendations, CL and IWG and things like that. So again, this is really just trying to bring, here's the context, the broader context that OEB exists in OHA. And if I remember correctly, that OEB and PEB sit in the Health Policy and Analytics Division within OHA. So again, just some context, thinking about the larger context that OEB exists in. I think we can, go ahead.
I'm sorry, I asked this question last year, but, and I could never find my notes afterward, but there's a widely held perspective with my members of PPC that PEB has much better benefits than OEB, and everyone's always asking why. Why is, because some of our members are married to people and they kind of get to do the side-by-side comparison. And so I remember getting a really helpful explanation last year, but I don't remember what it was. So
Yeah, I can
I
take
was gonna say, Ali seems to be the
Yes, we actually did Georgianne and I did a presentation to the OEB Advisory Committee that looked at PEB and OEB and did some comparisons, looked at demographics and composition of the pools. And really it comes down to OEB has some similar plans to PEB, but it really comes down to collective bargaining that determines, the employer contributions. And I would even take it a little further than comparing PEB and OEB to comparing the entities within OEB is really kind of all over the map. So there are some that actually have better contributions than PEB does. But for the most part, it's not as good. It's OEB employees and it's pay a higher cost share than do PEB employees. But PEB's a cafeteria plan, a Section 125 cafeteria plan is basically one employer, the state. And with a cafeteria plan, you have to offer the same plans to all employees at the same cost. Whereas OEB, the cafeteria plan sits at the entity level, so you have over 200 different entities, and that's how you pay for your benefits pre-tax contributions through payroll. And OEB is set up statutorily like an exchange of plans. So the initial statutes of OEB said that the board had to offer the lowest cost plan to the highest cost plan as far as plan values. So from platinum to bronze essentially. And then OEB used to offer probably 3 times as many plans. Now it's kind of been reduced a little bit, but it still offers a much more varied menu of plans. And each school district, each group within the school district can choose to offer certain plans for that school district, which unfortunately the board can't control.
Yeah, and the reason why OEB has 2, right, different health insurance
Carriers, yeah.
carriers,
Mhm.
that has 3.
Yeah. But PEB has about a third of the medical plans.
And OEB used to have 3. Providence offered OEB plans
Yeah.
until, maybe like 2013 or 2014, there were plans 4 and 4A, which was a Providence medical home plan, but the rating just became unsustainable. And so the increases were so high year after year that the enrollment wasn't.
So it is possible to have a 3rd carrier, but it's just not.
It just comes down to what's the unique value of the 3rd carrier. It's a trade-off between choice, and the Kaiser and Moda models are so different. Kaiser with its HMO, it's why Kaiser is like very commonly offered alongside the PPO plan because it's delivery model with the way the care is integrated. The delivery model is so unique. Can't really be replicated by any of the PPO carriers. So that is a really clear choice for members which one to go into. When we start thinking about offering multiple PPO networks that are multiple PPO choices that have like 95% of the same network, we just want to be thinking about, why. But yeah, we can have as many carriers, like you can have as many carriers as you want or as few you want. Sorry, Michelle.
Yeah, I'd be happy to share that
That's follow.
presentation,
Yeah.
but you're right, there is a disparity. And if we can get all entities to offer the top, tier plans to all employees and with a really, really high contribution, I'm sure that, there'd be consensus to do that, but it's unfortunately the board scope of authority is really to offer the plan designs. And as far as premium contributions, that's really the employer.
So does PEB negotiate,
Yeah.
they bargain.
The board doesn't. It's the union. We just, that has to follow the collective bargaining agreements, just like OEB.
So if I understand, one of the components is the bargaining because the PEP, most of the PEP employees are statewide bargain contract, right? ACIU, and some of those are fellow union siblings. We are the republical entity separate, so there's more democratic or independence on that perspective. And then we also have to either change policy and then change how we do with bargaining, but also the OEB board has to, like, three systems have to be aligned to make that possible.
Yeah, and there's also compensation and salary that's part of those negotiations too. And then there might be some school districts or bargaining groups within the district that prioritizes salary over benefit contributions or vice versa. I'm not an expert really on the negotiations there, but I do know that SEIU with PEP has always prioritized number one, the benefits contribution and keeping that for salary. But there, again, there is a disparity, there's no doubt, and I'd be happy again to share the presentation.
No, I think I think you've hit on it. It really is, OEB is, it's multi-layered. We'll talk about it a little bit more this afternoon. Who's really making the decisions is completely different with OEB than it is with PEP, because those entities are the ones that are driving that through their negotiations with them. Everybody's a little bit.
Appreciate the differentiation between what's the local level and what's the board level. That's helpful. Stepping out just a little bit wider, I think my question is not so much around the what, but the how do we get to that answer of what are the provider options that we set on the table for local purchasers to choose from, not the plans themselves, but the providers. How is it that the OEB board makes that decision? What's the timeline for that decision making? And what are the milestones and what are the processes associated with that decision making? Really interested in knowing what that looks like. If today is the beginning of I can't yet, just based on my naivete and rookie status, really see what the milestones are that are out there. If I could see them, it would help me frame my questions around what I see are end user needs, if that makes sense. So to play that out just a little bit further, I hear that we've had a third provider before that's been available, and yet I don't fully understand. Yes, they have the choice to apply, but if they're not applying, what's the why on that? Is it that there's a request for proposals that OEB puts out in terms of public procurement? If that's the case, what's the structure of that request for proposals? Because that's where it would seem to me as a governing body, we would have the authority is determining what is in that RFP around defining priorities. Because priorities are communicated in that RFP to all the potential providers. And I can't yet see where my voice can inform that process until I can see maybe the timeline. And even to know whether I have to around this idea of an RFP for public procurement, because you're a public body, and it seems to me that we have to follow the same stuff. So I'm going on down a rabbit hole there, but I'll stop. Somewhere there's a question or two.
Yeah, those are actually great questions. I think that, PEP used to only have two carriers for quite a long time, Providence and Kaiser. They went out for an RFP and added MODA and a couple CCO plans, CCO-like plans that were dropped a couple years later. But they are going out for an RFP as we speak. They have posted it. And so who knows if they'll end up still with three carriers, additional carriers, or back to two. But you as the board, that's your leverage, is to go out for an RFP. That's where you purchase. But I would say the number of carriers, there's an upside to, and there's downsides to both. I think, OEB's had really great partnerships with both Kaiser and MODA, and with two carriers, you have a little bit more control to kind of design your benefits, work with them. They'll work with you back to even change their business model to accommodate you as a large purchaser. Where I would say with PEB, something that they lost when they took an additional PPO carrier, maybe they got some competition there, but I think they lost maybe some of the purchasing power and leverage that they had just with that one PPO carrier. So there are advantages to both and disadvantages, but an RFP is something we plan to talk about because that is at your discretion as the board. And 2 years ago, we at this retreat, we actually had an extensive conversation with the OEBB board, and the board voted not to pursue
Gotcha.
RFP at the time.
It's on the January agenda.
It's on the January agenda. So this is
The renewal cycle is on the December agenda. We'll go through that, what that looks like.
helpful for me to see those two markers out there.
Yeah, great question, though.
I would also add, the other thing that the board has in its control is really the types of plans offered, which is almost as important as the carriers that you offer. So today you offer PPOs, you offer, high deductible health plans, and you offer an HMO. And so it's really the two. It's, what carriers are you offering and what types of plans are you going to offer? And again, this kind of segues nicely into this slide because this is talking about what is in the board's purview. And so it's really the board is here to kind of set the long-term and short-term goals and figure out how they want to achieve those goals. And we just talked about the number of carriers. So that's the number of carriers, the plan types, the plan designs. That's also within the purview of the board. And also when to take them to the RFP, which is, a key decision that the board makes as well. The other part of the board is really the renewal negotiations and how to manage the performance and the accountability of the carriers. So that's also within the board's purview. And that's done through reporting, through performance guarantees and other tools as well. And then also the board partners with these advisory groups. So there's been a long time partnership with IWG, and then kind of a burgeoning partnership with the health equity work group as well that we're going to be exploring today. And I think the other piece that the board has purview on is around wellness programs, in terms of across all health plans. So I think that's probably helpful to kind of understand this. And that's why we wanted to start with this conversation is these are the things that are within the board's purview.
Within the board, we have a subcommittee that reviews the RFPs to you out getting that.
There's a pitch.
Can I clarify that on that? So between now and February, when the board takes action on the RFP or it's not RFP, am I hearing there's a separate task force of the board that will do that analysis?
Yeah, in the winter, we will get the plans and we'll get the providers and we get to this ranked like we did with the counseling services, and we get to choose companies that could be working with us as partners. And it's a lot of work. This takes some time, but that's later on the year. Yes.
I mean, review the various providers prior to an RFP?
Can I jump in maybe with a clarification around timing? Yeah. We work on multiple plans at the same time, so it can be incredibly confusing because we're already thinking about 2028. We're still in 2025, and OEB's plan year is off calendar year, so it's a complication too. We are in the renewal cycle for the 26-27 plan year. There's not an opportunity for the 26-27 plan year to do an RFP for OEB for many reasons. The public procurement process is a lengthy process that requires a lot of advanced planning and resources. Namely, the PEB RFP is underway. Also, we would want as a board a lot more time to think about our approach for that. The discussion in January is to kick that process off and really talk about what's our desire, what would be some of our goals, how serious are we about that, because it is pretty resource intensive. So this upcoming renewal is for the 26-27 plan year. So we'll be with the same carrier partners for 26-27, but John made a really important clarification, which is within the choice of carriers that we have, they can do a ton of stuff for us. So we can add vendors and vendors and point solutions. We can add different programs, different plan types, different numbers of plans, different benefit, like whatever we want, there's still flexibility. And then the RFP process for OEB, so then the question would become with the planning process. And then, so there's a big planning process where and I say we, of course, the board makes the decision, but the board decides on its priorities for an RFP. And there'd be the whole RFP writing process and then issue the RFP. Whoever would want to respond to the RFP gets to respond to that. And then this is sort of what Enrique is talking about. There's opportunity for board involvement in the before issuing process. Right, so in drafting some questions and giving input around that. And then also there's board involvement. And I don't know, Bonnie, if you were part of yeah. Bonnie can speak to this too. There's also board involvement in the scoring and response reviewing part of the effort. But we're talking about, I want to give you years, but it's probably not 26. How's that?
Like 2 years, yeah.
Yeah.
So it's like 56, 27, is 28.
It's probably work in 27 for 28, 29. But again, I don't want to, don't hold me to that and just the point is that it's out a ways because the process is lengthy, even after we make a decision for the carrier. We need time for implementation before open enrollment. So that's where we start to get this timeline that's out pretty far. Is there's the planning process, the RFP process, the evaluation process, and then still time for implementation before 10 months.
Okay, go ahead. No.
Through the chair, I
Yeah,
don't
go
need to keep blurting out.
No, it's fine.
Me?
Yeah.
Barney may tell me to be careful on this, but I'd really like a clear timeline because if priority number 2 in sphere of influence is competitive market, I'd like to know what it will take for this board to make a decision to open the door on public procurement process that includes RFPs. I'm hearing maybe 28, 29, and I totally appreciate the complexity of it. But I think we owe it to those we are providing service to make a fully informed decision. I don't feel like I'm one unless I can see specifically what that timeline would be from beginning to end on an open RFP process. Because absent that, I firmly believe that we're not living up to sphere of influence item number 2 up there, a competitive market.
Yeah, we're definitely going to include the timeline in the
Okay.
January presentation. Yeah.
Perfect.
If I could just add, one advantage this board has is they'll be able to see what comes out of PED. And some of the learnings and clear to even work with the current carriers on implementing something similar or desires to do that, or, whether to go out for an RFP. So,
No, it's okay. There's a lot of thoughts rolling in my brain, so I'm not going to math right now, but if I'm still on the board at the time, which I think I will be, I would love to be part of that. Okay. Additionally, just to make sure, in layman's terms, that I understand if OEB stays with 2 carriers, that creates more guarantee for those 2 carriers, right? Because they're competing with only each other and therefore gives us a little bit of leverage, right? It helps them, helps us, and, they're probably more willing to work with us because there's a higher guarantee, right? Ish. If we open it up to 3, there's less, now it's spread out to 3 and does change the leverage, right? To some degree.
it was really noticeable with PED when they went to more than just the 2 carriers, just the lack of responsiveness maybe you get with that major carrier. But, there are trade-offs. So.
Yeah. Okay. I just make sure I put that correctly. Thank you.
Really, there isn't 2 carriers. In 2/3 of the state, there is not 2 carriers. There's 1. Try to get Kaiser in Hermiston, or any of Eastern Oregon, or any of Southern Oregon, Central Oregon. This is 1.
I just have one quick question for the people at Mercer. Is there a best practice on how frequently it makes sense to do an RFP? I certainly don't want to do it every year. I don't want to wait 50 years. So is that 5 years, 10 years? The best practice?
We've previously talked to the board about something in the ballpark of every 10 years. OEB is unique from the commercial market in that the public procurement process is not the same thing as a month-long commercial RFP process, right? Like the timeline that we were just talking about, it doesn't make sense to issue an RFP every 3 years if it takes 2 or 3 years to do the RFP. So that's one of our primary considerations is the time and resource invested. We agree it's time to consider that, and Ollie mentioned being able to provide more of a concrete timeline in January. The last RFP was in 2017. So we're right around that time where we need to start planning.
The planning started in 17 or the implementation? Was it?
Implementation.
Implementation in
Yeah.
17.
It's worth noting though, that RFP, OEB ended up with the same exact 2 carriers as they had before that.
Yeah, that was my first year on the board, if I remember correctly. And the issue was in an RFP, we set standards out that the carriers have to agree to. We opened it up. And Providence said, no, we're not going to agree to your standards because we can't make it work. And so that could happen again as well. And so I think that's part of the discussion on whether we open it up or not. Is there another set of carriers that will offer what MODA, Ollie Kaiser, what MODA's offering according to the standards that we as the board have set, because we don't want to go backwards, obviously.
Yeah, I would just note that it's like we said, no less than a decade. Many other states have requirements in terms of how often you go out to bid. Oftentimes it might be 5 years or what have you. But, our understanding is there are no requirements around this. So it's kind of putting it out in the open.
Heard Ali say a bit ago that in advance of or separate from an RFP process that providers have been responsive to OEB's request for some considerations or some adjustments.
Absolutely.
And I think in the 2-year period during which we'd be in this process, it's a great opportunity for an on-the-job interview, right? If we want to press a little bit more something, I'd like to engage in that conversation at some point, whether that's in again, task force or a full board meeting around what could be those improvement areas we might look to experience from an end user standpoint.
The process for that, Tony. So as part of the annual renewal cycle, there is a formal process for that and an opportunity to do what you're doing. So let's think through that for a minute. So we issue formal renewal letters, which are actual documents, to all of our carrier partners, medical, dental, vision, the standard will get one, Canopy will get one. We issue formal renewal letters. They are going to go out on December 5th. The carriers generally have a month to work on those and answer our questions. We'll get responses back in the beginning of January. In fact, I can tell that Tony, like me, you are a visual thinker. And so I appreciate that about you. You have a slide. If you don't mind, Rose, can you jump to slide 83, please? And you can see it. When we agree with you that each renewal process is a mini RFP, and it's a chance for us to tell the carriers, hey, we want you to do X, not Y, or we want you to do Z better. When we come together on December 2nd, so today is a good opportunity for us. So we're already taking notes on things we identified today. So today you could say, hey, Kirsten and John, hey, Mercer team, I want this in the renewal letter. So that's already available to the board. It's effectively available, just to clarify, it's really available to you all the time. If we're outside of the renewal cycle, we just make a note for the next renewal cycle, or maybe it's something we can handle off renewal. But it is always within your scope to ask us to include something or direct the carriers to do something. So now we are starting to plan. Last month was the kickoff really where we're looking at data. And now we're in the planning phase for what goes in the renewal letters in December. Of course, it's a partnership between Mercer and the board because trust me, you all do not want to write the renewal letters fully and come up with all of the more of the mundane things that go in, the procedural things. But the strategic things, the interesting things, that's what we can talk with you about today. So throw ideas out there and let's talk about them, and we'll rethink the agenda for December also to make sure we have some more time as a board to talk about. This is what we're thinking in the renewal letter. And I've already had the conversation with MODA, who, yes, we have a carrier partner in Kaiser. Kaiser's a national carrier. They have less flexibility than MODA. MODA essentially does whatever the OEB board wants them to do within reason, because you are a very valuable client for them. So I've already said to MODA, like, we do not want to make benefit changes come April, right? That's one of our priorities. MODA does not want to make benefit changes either. It's like, you know, within the realm of things that are like safe, you know, the safe and normal usual changes we'd ask for, like, what else can you tell us? What other ideas, even if we decide not to do them in the end, like, we have nothing to lose by hearing all of these other options, to the extent that you can identify creative things for us to be thinking about this renewal cycle. So they're thinking about that. We always have a question in the renewal letter that's like, what haven't we asked about that you want to put on the table? So carriers always have the option to tell us whatever they want to know. But today, all throughout today, is an opportunity for you. We are always happy to go off script. So we can go down rabbit holes all day long. You know, it's just up to your guys' direction, what's helpful. And we'll carve out more time in December. Maybe we could do some breakout groups around the renewal letter and putting more questions in. We can, maybe at the end of the day, in that extra 20 minutes, we can, I'll make a note. Maybe we can circle back to this topic and see how you're feeling.
Can I just like, make one comment, which is that, like, I really bristle at the idea of us having this like cooperative relationship with carriers, and I do appreciate like that you do cooperate with them, that we have extracted some concessions from them during these conversations. But I mean, we are like, our members are the frog in the water that's slowly boiling, you know, like if you look back, you know, I look back over the last 10 years, my healthcare has gotten more expensive and the quality of it has gotten like profoundly worse in almost every way. And so I just want to like make sure we have that perspective of even though we are in many ways lucky to have the insurance that we have, the idea that we're working cooperatively with these health insurance companies who are taking $10,000 to $15,000 of my money every year for premium and making everything so hard and resisting every like thing that I try to active care for, like it just that story does not align for me. Like I do not think of them as partners or good actors.
So what I'm hearing, Kristen, is that if we go back to the agenda, we can still discuss the utilization data and the cost to give more perspective for our new board members. But I also want to add that the last comment, I do feel that we are the purchasing power for those carriers. So I think it will be on the best interest of the board if the team with Ali makes recommendations or have conversations with carriers to inform the board on this is what MODA and Kaiser are suggesting and advices on the decisions that you make. Or obviously we're the governing body and staff have the role of operations. What I would like to hear more on the summary note in every meeting. This is our dialogue has been with them, and this is what they're proposing, and this is what we're proposing based on the data that we have. So we have more transparency or more sort of engagement with the board, and I think they'll bring that to life to us, and then we can further inform ourselves when it comes to the renewal process. What has MODA done and what has Kaiser done for us? Just in case maybe somebody else comes into the table and like, can you do this? So I think that'll be helpful moving forward. So I appreciate that. Thank you.
Oh, yeah, if we could go back to slide 12, we'd just like to quickly finish slide 12 and 13, I think, and then the opening. So what we're going to be talking about on this is really things that are outside of out of the board's sphere of influence. This is really, I think it's better to think about it. What do entities do? And Georgianne will get into this a little later as well. But I think the key thing here is the entities provide input and feedback to the board in terms of the plans and things such as that. And, they also determine which plans to offer to their employees. So again, not just the carriers, but the plans themselves. And they determine the employee contribution levels, which is very key, and whether to provide, HSAs and HRAs, which are different forms of arrangements that help, allay contribution levels. And then they also, the entities also have their entity-specific wellness program. So I think that this kind of helps you understand what the entities are doing and what the board is doing. And then if we move to the next slide. Thank you, Rose. So I think that this one is really maybe helpful to understand the value that OEB brings. And because OEB brings more than just the purchasing power, I think that's what everybody thinks about when they think about OEB. I think it's much, it's much more than that. That's the experience rating. It is the protections that, SB 1067 offer in terms of the hospital payment cap. So there's a host of financial things that OEB brings. I think one of the key things, especially we'll look at this later, that there are many OEB entities that are fairly small. If they didn't have OEB, they would not have the range of plans offerings. They would have probably one plan they could offer, and it'd probably be a lot more expensive than what they are getting through OEB. So I think that's important to think about, that it's really, plan choice is a key thing, especially for the smaller districts. And then I think the other thing too is really the carrier performance management, and this is really what we're just talking about here. Because the thing is, there aren't a lot of choices of carriers. So I think that it really behooves the board to manage those carriers intensively. And that's one of the things that OEB brings to the table. I think the other thing too is really the communications. So the thing is that there's a very robust communications program that OEB offers the entities, monthly newsletters throughout the year. And that's a lot more than the entities could offer if they were on their own. So I think this slide might help board members in your discussions with the stakeholders that to help understand the value that OEB is bringing to them.
I do want to add on the improved communications.
Mm-hmm.
I know there's two of our, at least within the OEA family, we have two large locals who currently have about 6,000 members total. We're not part of OEB, and they're starting to be very concerned about the insurance. And they're large locals and they're healthy, but also in Southern Oregon, in the Springfield area, Eugene, there's two locals who have asked, hey, you should join OEB, and for some reason they think that they're gonna better end of the deal. They probably are, maybe, but I think it will be in the best interest of OEB if we wanted to bring more people along to improve our communication on our benefits. I think that what you were speaking to earlier, Ali, about the difference between PEP and OEB, I think all of us here sort of understand that piece, right? But I think there's a perception in the public that PEP is more advantageous and has better benefits. So maybe we can start thinking about, I'm not everybody reads email, but in a way that it's engaging with superintendents or others and us to bring more people along. Because I not talked to the second largest local in OEA to come to OEB, and there's been, well, yeah, maybe, and I know there's members who want to be part of OEB, but I've recently learned, I might be wrong, but it only takes one member to say, I want an audit of my healthcare providers, and that's a benefit for our members. once that triggers, OEB can come in and do the assessment. Because the leadership might be not wanting to do that, but the rank and file individuals do. So I think that's something for all of us to learn or to promote within our organizations. I guess I don't want to be on.
Yeah, no, I was gonna ask Georgia, we're gonna talk about that a little bit later about your conversations out.
I will certainly include that in the affordability comment because it's, I hear it all the time. I'm the liaison to districts out there, and this year we've had a lot of charter schools. They're smaller entities, and they are getting 27 and 28% increase. And their rates are outrageous. And they have no choices. They have no options because they're small. And they're looking at this, they're going, thank the Lord for OEB and the ability that we can get in here. So it's really starting to understand that because it's also outside of OEB and TAP. There's a whole big world out there. And if you talk to people out on the street, they'll say, wow, I wish I had OEB benefits. Man, you got OEB. You got those great benefits. It is way better than what you're gonna find in a lot of places out in the local market. So,
But I think on that Beaverton,
Yeah.
you know.
I was thinking about Beaverton.
yeah, Beaverton is,
Mostly the Westland, there's some, you know, inherent regional advantages that they might have, but
Yeah.
I think, you know, they should do their fiduciary responsibility and explore all options, you know, and they might be surprised. I mean, I know we have part of Portland that requires, you know, you might be surprised, because they're facing, you know, double-digit increases in 3 days of paper. There's been, you know, a lot of stories. I think everybody's really facing some challenges right now.
I mean, Ash should probably know this, but I haven't checked OEB's social media, but if we have an Instagram account, because that's how most of our individuals are communicating now, I think it will help with that message that OEB does have options, and the more people we bring, I think that will give us more leverage. I'm just trying to be creative of like, well, improve communications. Oh, absolutely. I think we're losing the message on CAP and OEB. Thank you.
I'm curious, is the richest plan that OEB offers, is it comparable to the PEP?
Yeah, it's the Moda and Kaiser.
Yeah, it depends too now because we have Garner for Moda. And so even though we increased the deductible on Moda's richest plan from $400 to $700 this year, there's a Garner HRA incentive of $700 for individuals. And so in some scenarios, a member could be having a $0 deductible health plan for OEB. In general, the benefits are richer.
High deductible plans and have either.
I would just say if a person wanted that rich plan, could they choose it under OEB? That sounds like they could.
If their groups offer, you know.
you know, the opposite.
And if they're out of pocket for the premium, it vary by who they work with.
Exactly.
Now they have.
But you know, even if all of our entities offered all the plans, that doesn't solve the structural issue of whether people can afford those plans in the first place, because the funding model for OEB entities and the state totally different. Each district, their major revenue source is based on student enrollment. If student enrollment's declining, they get more money. And so it really, when we bargain in our contracts, and I think that's true with you too, right? You really do have to decide between, a lot of times between compensation and the employer contribution. So the availability of the plans to a certain extent is secondary to how much the entities are putting into it.
5%, the district offers you 5% total package. You're gonna have to pick, do I want to do the 3.4% increase for insurance and then take the 1.2 in my pocket? Or do I want to take the whole 5% Cause that money's gonna go into how much PERS I get in my future, if we're thinking that far ahead. Well, it's always a dilemma when we go to negotiate. How are we going to split this 5%?
Georgianne's been such a huge resource for us, helping, going out there and helping with these discussions and plan selections and helping understand the process a little bit better, especially smaller entities.
Speaking of Georgianne, I know Georgianne prepared some slides for today. Because it's what we've been talking about already, I actually wondered if it would be advantageous to set the stage with the rest of you just quickly walk through your slides now instead of after lunch, since it seems like that's the board's area of interest right now. So Rose, let me get you a slide number. So Rose, if you don't mind going to slide 63, please. Thank you.
Bingo.
Do you want to trade seats for yours?
I'm good here.
Okay.
So affordability, when we think in terms of affordability and the OEB program, there's actually 3 layers of affordability that go into this. And the first one is at the board level. So the board has control of, the affordability that you're looking at if you got to meet the 3.4% limit. That's in law. You have certain levers that you can pull. Obviously, one of them, but it's negotiating, finding efficiencies. That may be, to the renewal process, the renewal letters. Are we going to add services that will help keep costs down, keep people healthier? How can we help people do better with their plans? You can use reserves. We talked about the RSR, that building up. So you have reserves that you can use to make it more affordable. You can buy it down. And you can make plan changes. And that was the decision that was made for the 25-26 plan year, was to make plan changes to get that premium down, to meet that 3.4%. Those are the areas that the board can really have control over, is what you're bringing to it overall. Next slide, Rose. The entity level, these are the areas of affordability that they're going to look at. They are going to be looking at what is the contribution amount, what plans are they going to offer, are they going to use composite or tiered rates, and are they going to include HSA or HRA funding? Is that something that they're going to offer? And those are pieces that the school district, local government, those are the pieces that they can pull in affordability. Next slide. And then you have the employee level. So this all filters down. You get to the employee, and the employees looking at the affordability, and this is something Michelle's talked about. The employees looking at saying, monthly premium cost. What is my for sure cost going to be? How much is coming out of my check every month? Whether I use services or not, how much is it going to cost me? And the other side of that is, what are the cost of services? So if I have a higher payroll deduction, I may have a lower copay. That works for me. Others may be, I need a lower monthly cost because I've got lights, water, gas to pay, and I'll pay more when I go to the provider. My copays, my deductibles may be higher. And those are the levers that the employee can use. Next slide. So where is the most impact? It really is at the school or entity level. It is negotiated. It is a management and a union negotiation about how they're going to set that up. What are the pluses? We've heard some conversations about this. What are we doing compensation versus benefits? What does that look like? Different budgets and different needs in different districts. That's the other thing. We've talked about, you don't have 2 options across the state. You also have great differences in these districts. You've got small districts down south. Think about like Lakeview and those areas. Malawi is another area that, it's kind of out there. They have completely different needs and different budgets than Beaverton, Tiger Tualatin. They have different things that they're having to look at within their districts. and their budgets. That is another thing that's impacting them in that decision-making process. And it's not gonna be the same decision-making one district to another because they're gonna bargain differently, they're gonna have different needs. The other thing that the entity does is they really control the dollars all the way through. They control the dollars given to the employees for premiums. It's through that bargaining process, but how much is the contribution gonna be? Is it gonna be in one district? It might be, well, you're gonna pay 10% of the premium. In another district, it might be you're gonna pay 1% of the premium. And it can be customized. The other thing is like, well, what plans are you gonna offer? So the school entity really has an impact because they're controlling the dollars and the decisions. Next slide, please. So contribution amount, if we go one layer deeper in this, let's think about contribution. Is it going to be a flat contribution or is it going to be a percentage of premium? Is it going to be a percentage of some standard? Every district can make that decision based on what they negotiate. Will there be any plans covered in full by the contribution? Is the entity or the district going to say, you know what, we want to have one option here that they're not going to have any out-of-pocket monthly expense, no for sure cost, it's going to be paid. Are they going to have a plan that's covered in full that an employee could choose? District choice. Use of contribution dollars in excess of premium. You have some districts that will say, we have given you, here's your $1,900, choose your benefits. And if there's money left, they may say, here, you can take it as taxable cash. Or they may say, let's put that in your 403. Let's put that towards retirement. They can make that decision on what to do with those excess dollars, or they may say, well, you didn't spend it all, so it's going to come back to the district. And we're going to set up a pool. And different districts do it differently. Some just let the employees have the money. Others say, nope, you've chosen your benefits. We're going to keep those extra dollars. We're going to put them in a pool here and we can use them in other places. Opt-out benefit. Again, they have the decision to make. Are you going to allow any of your folks to say, I'm going to bypass the benefits. I want cash instead. So I'm going to get some kind of a compensation in lieu of that benefit if I opt out, as long as I can prove I have group coverage, because we want to make sure that everybody has coverage. So are we going to incent them to opt out of the benefit? Or are we going to really encourage them to stay in the benefit? Again, these are the decisions that the entities face, and it's going to differ by everybody. Next slide, please. Plans offered. We've had this question go too. How many plans should we offer? There's 7 MOTA plans. There's 4 Kaiser plans. How many is too many? How many employees do you have? What are their needs? And you're negotiating, you're bargaining. What are those needs? What do they look like? You know, the entity has that decision of how many are we going to offer? We're going to offer the richest plan. A lot of districts don't even offer Plan 1 Kaiser or Plan 1 MOTA. They don't even offer the richest. Are they going to include any of the health savings account options? So Plan 6 and 7 on MOTA, HSA qualified. So are you going to offer those? And if you do offer that as an option, is the district going to fund any portion of that HSA account? Because remember the HSA qualified plan, that's what MOTA brings. But the actual account, the savings account that goes with it, is owned by the employee, by the member. And they can fund that with pre-tax. The employer can fund. But is the employer going to do that or not? Is the entity going to, is it their philosophy that we want to bundle medical, dental, vision? So we want everybody that enrolled, we want to make sure they have a medical, dental, and vision option. And they can set up the contribution such that if you choose this plan, here's what you're going to get. We want you to have all 3 of these. Or are you going to say, as a district, you can choose. You want medical, no vision, no dental, that's fine. Next slide. Composite or tiered rates. depending on your district and the enrollment that you have, composite rates are great for family coverage. It is one premium regardless of how many people you're insuring. So I've got my 7 kids and I've got this amount. I'm single and I'm having the same amount and it's just me. That is something else that needs to be discussed because people can get upset about that. Tiered rates. So if you're going to do an opt-out, something like that, you may want to look at tiered rates. Or if you have a younger population in your district, you may have younger people that don't have large families. A tiered rate might make more sense. So again, a decision that's made there. And all of these work together to figure out what they're going to offer the employee so they can Next slide.
Alexa, I mean, Georgianne can also say that it's not just the tiered rates or composite rates. A lot of our contracts decide between tiered and composite contributions, which
Absolutely.
makes it even more complicated.
Absolutely, absolutely, because it's, that's something we've been looking at with some of the districts saying, you know, do you want to keep your composite contribution and offer tiered rates? There can be some moving pieces there. And we talked a little bit about HSA funding, but also HRA. There are districts out there that sponsor HRAs, health reimbursement accounts. So they're putting money in that account and unreimbursed medical expenses, the employee can tap into that HRA to have that. So those co-pays, those deductibles. So do you want to offer a higher, as a district, you want to offer a higher deductible plan, lower premium, so for sure cost is lower, but you're going to put some of those things in an HRA and you'll pay when services are rendered as opposed to for sure every month in the premium. So they can really be used to supplement that. And then again, we've already talked about HSA. Is the district going to do any funding of that HSA account? Lots of moving pieces at this entity level that make it, and it is different in every district. So you look at PEB, PEB is kind of a big central thing. And with PEB, it's like, here's the deal. Here's what you got. You can like it or not like it. You're going to have 5%, you're going to have 1% contribution. That's what it is. These are the plans that are going to be offered. That's it. Whereas on OEB, you have so much more choice, which you need. I would argue you really need that because it is different across the state. There's different needs in different parts.
Oh, George.
Dr. Elias, that's Georgianne, staff of OEB, who's explaining the composite of how the decisions are made of the plans and the impacts of the cost of each plan. And her role, if I'm correct, is to go out in the field and to recruit or bring people into OEB. And when she has discussions with the bargaining units or with the administrators, she presents exactly what you're seeing online. And it's ultimately to the decision of the school districts to join the OEB or not.
She also serves as a resource liaison.
Thank you.
Yeah.
There's a question.
One other complicating factor too, with school districts is there are so many part-time workers. And I think on the state level, there probably tend to be more full-time, 8-hour-a-day employees. School districts, they don't work a full calendar, full 12 months. They don't work 8 hours a day.
Excellent point, Rick. And what do you do? What benefits are you going to put out there to those part-time? I know community colleges have a lot of that as well. What does that mean? I can't remember if that's the last slide or not. Can you, next slide? That's it.
So we're wrapping up. Are there any questions for Jordan before we move on to a break? And then the next topic will be the director's topics. And then we gotta come back and discuss dental and vision and the pharmacy follow-up that we had in the previous meeting. since we had questions. Any questions? Yes.
Not a question, but just a comment. In my role as the benefits coordinator at 4J, I'm also part of the Joint Benefits Committee, who chooses what plans we offer. And, we have a specific structure of, contributions go into our reserves, and the Joint Benefits Committee determines how we utilize those reserves to subsidize rates, even more so after district contribution. So if anybody wants to kind of like ask any questions about how we do that, I think we have a really great model here. Our premiums are really, really affordable. So I'd be happy to answer questions later when it's more appropriate. Yeah.
All right, so it is break time. Ali, do you want to lead us, and we'll come back at 12:15.
Enrique, just one note. We jumped around a little bit, which I think is confusing the day. Maybe a break is still a good idea. Yeah, but just how about a 10-minute bathroom break, and then we can come back and we'll do one more. We'll do either 4 or 5. The Mercer team will confer, and then we'll break at 12:10 for lunch in our regulatory roundtable to get everybody energized, and then we can get back to the normal agenda schedule.
Do you want a 10-minute break?
Let's do a 10-minute break for bathroom and whatever.
Thank you. 10 minutes. An hour.
For like an hour.
But I don't.
Enrique? I'm gonna move it upstairs one thing, they're still in there.
Yeah, same thing.
Think of one.
Yeah, bathrooms are gonna try to do. Oh,
Yeah, I took the hall straight back to the left. We're trying to make a little.
Yeah.
Hey, Kirsten? What slide are we gonna start on? You're muted. It's okay.
what I think.
That was quick.
All right, so thank you, and for us to sort of get back on track on the agenda, the next presentations, you're always welcome to ask questions, but we make sure the questions we have, we stick to the part of the PowerPoint, and if make a little note if there's a question that relates to a different topic, so then we can address the question at hand in the PowerPoint. I mean, I was really happy with that. We were able to get the staff to jump into their presentation, so we got off that of the agenda already. So good on us. But yeah, so I'll let you guys continue.
Okay, thank you. Rose, can we go to slide 17, please? Again, thank you, board members, for the privilege of your time. I'm going to sort of continue and dive into the cost utilization data. This is the follow-up from our October discussion, and this is a deeper dive. But I'm going to summarize some of the takeaways. There are some quantification slides here, so if you want to kind of dive deeper. But again, open to questions about this, but let me start there next slide, please, Rose. So as we kind of look at the cost utilization data, this section here will lead to our clinical renewal strategy discussion and the priorities that you may sort of direct us to focus on. So this is sort of what I call the clinically based data-driven informing of the discussion that will be forthcoming. That being said, we always, as we dive into the priorities set by the board, look at some of the data related to cost utilization, there's always this lens of health equity that we want to put on top. So health equity is obviously important as a standalone topic that we put focus on, but we also want to apply it in context as we look at utilization data. There's just flaws in averages. Averages are useful, but as we go through, we'll start to identify some differences in correlations with some of the data we see to a couple of dimensions that we'll dive into. One is between rural and our urban geography, and the other one is with ethnicity data. That's the data that is available.
Is the sound on? I just got it. Okay, thank you.
Yep. Okay. So with that in context, next slide, please, Rose. The key takeaways that we've summarized here, as extrapolated from the set of slides that follow this, is as follows. And happy to just kind of walk us through this. So the demographics, when we look at the urban and rural demographics in context of the membership, it's a 75-25% split in terms of volume. But when we look within the key demographic features like age, etc., male-female mixes, it's very similar between rural and urban population. 75% urban, 25% rural. So just keep that kind of in mind. We also kind of looked at contract size, meaning for every educator or associate, the number of spouse dependents that come with that educator. Again, it's very similar across urban and rural communities. The percentage of non-claimants, those members, and this came up in an earlier conversation, right? Those individuals that are paying for this coverage, but we don't see any claims for, are also very similar, and it hovers around 6 or 7%. Oftentimes, what we see across my other sort of employer clients, they sometimes are more around 10 or 11. So just as a point of reference, I wouldn't call that a benchmark. That's just sort of the data that I see typically hovers around there. So hopefully that's informative. When it comes to utilization, some correlations between differences around rural versus urban stood out. One is rural population does have higher ER utilization with concurrent lower office visits, right? So now the question is, are those two correlated? Because of the difficulty, I'm assuming, or the availability and access is leading to a higher ER utilization. So something to think about. When it comes to preventative cancer screening, there are differences existing between breast cancer and colon cancer screening rates for the rural population, as well as certain race and ethnicity. So again, when we look at the average, it is lower for breast and colon cancer, but then there are some unique call outs based on geography and race ethnicity. We did put some effort from last year's clinical strategy discussion. So we are being sort of more proactive with some of our cancer screening communication. So it'll be interesting to see if that's addressed some of the differences that we're seeing in this data. So this data does have some lag between what's going on, boots on the ground. So keep that in mind. Mental health obviously is a very important area for our members. But again, we're seeing differences with higher rates of diagnosed. So again, I'm looking at claims data. So it doesn't mean that what's in the actual population, but based on utilization data, we're seeing higher rates of diagnosed mental health conditions amongst the urban population relative to the rural. However, the trend is moving faster for this rural population with an 11% sort of trend from year to year. When it comes to cardiovascular condition and musculoskeletal, higher rates in the rural population. There are differences in the utilization between certain utilization by race and ethnicity as reflected in the data that follows. So let me just pause there. So that's sort of the takeaway from slides that are following in this section here. Anything you want me to dive a little bit deeper into?
Just have a question, like, my assumption is yes, but in those rural areas where the screening rates are low, I'm assuming there are not specialists that are nearby or as many specialists that are nearby. I mean, I even know in Eugene for like pediatric specialists, you know, most of the time you're traveling to Salem, Portland for, you know, so that's the only, you know, comparison I have, but that's my wondering is, you know, is it access to the specialists, the disparities in the screening rates?
So Rose, can you move to slide 21? So the numbers behind my summary is kind of here in slide 21. It's a fair assumption. I believe there's some validity to it. We did not dive and do the more detailed analysis, right? And but I've got to believe that when it comes to, for example, colon cancer screening, the gold standard is a colonoscopy. That requires a GI specialist. I'm not sure they are as readily available. And keep in mind, for something like these screening tests listed here, they are considered zero out of pocket for the member because they're part of the preventative services. But that doesn't mean it's no cost to an educator necessarily. Right? So if you think about a colon colonoscopy, it's half a day to prep. You're not going to do that at school.
Mm-hmm.
It's a day to do the test and then to recover from because you're going to be a bit under sedation. So that's not zero cost, and plus travel and all those other things. So that's why I think last year, if we recall, for those who are here, we kind of looked at that and tried to request it, Moda to be more proactive, Moda and Kaiser to be in terms of communicating and being proactive and offering alternative U.S. Preventative Service Task Force recommended screening tests. So colonoscopy is gold standard, but you can also do at-home kits. Right. In the absence of doing that, I'd rather have a screening test done just to see and find those individuals that may need to benefit from the colonoscopy. The preliminary data that Moda shared with us did show increasing engagement rate for that. So that would be something that's worth looking at as part of the renewal process. But that was the purpose of that is colonoscopy is going to be limiting from an access, but there are other ways that we can do more screening. So the rates right now shows a lower for compliance rate for colon cancer. Be interesting to see if you do better with that at the next set of.
Yeah, I mean, if I didn't have a gastroenterologist, you know, close, I wouldn't want to have to drive an hour, you know, like I've had a couple of those, you know, like, you're right.
You gotta find family member or friend to drive back, which you're understanding.
right? But even the drive there with the family member or friends, you're still in an uncomfortable place during that drive.
So I think there's these practical things that lead to these rates, but we did not dive deeper.
Yeah.
into it.
Are the percentages, like people who are recommended to get those screenings, like, or is it overall?
Yes. Yes, these are based on meeting the criteria defined by US Preventative Service Task Force.
So only 20% and 29% of people who are recommended to get a colonoscopy are getting.
But then for breast cancer, we put in Gabby last year to try to identify and help really be screened for whether they're higher risk. Because now we're moving not from the US Preventative Service Task Force, we're moving now into younger age group that potentially need to also screen as well. So we're trying to cast a wider net, and that's kind of the things that come out of CL as well as the OEB board and some of the clinical strategies that we focus on.
Ian, do you mind just clarifying again for Dr. Laura your name and title?
Sure, yes. I'm Dr. Ian Chuang. I'm one of the Mercer subject matter experts. I'm part of the Mercer Well Practice, so I support PEB and OEB as sort of the medical consultant. Okay, and then the last point here is the preventative visits, right? So so these are the office visits where the purpose of the visit is for, I'm not here to address a diagnosis, not sinusitis or asthma, but just to screen and see if there's any health concerns that I need to be more proactive. So we have the rates are lowish. And if you think about that, plus the number of percentage of non-claimants, so that would be inclusive of people not even getting preventative screening. So again, those are things that I was talking about, Georgiana. How do we make sure members know that these are technically at zero out of pocket, recognizing that you still got to find time, get to that doctor's office and take advantage of the benefits. Okay, so take a look at those slides with more quantification. If there's questions, happy to answer them. But
Dr. Twain, can I add into, I just wanted to add that, as we this afternoon talk about the health equity strategy, this exercise that we went through in looking at these subsets of the population really informed some of these tactics that we're going to bring forward to you all. So just know there's a connection in our clinical strategy in doing the subsets. It's such an important component of this to kind of, again, uncover possible disparities, and we're bringing that forward as we're talking about the health equity strategy and the tactics that we're going to have you all look at to let us know if we're on the right track.
So these numbers are relatively low. So I'm assuming where that higher utilization is coming in is specialist visits, emergency room, like just in general, right? When we're talking about like generally utilization is higher. Right. And then, those are kind of concerning screening numbers. And so just my brain working, if preventative visit percentage was higher and all of these screening percentages were higher, we could catch things, doctors, not we don't, catch things sooner that would lead to, less extreme interventions or care, like when something is far worse, right?
So screening rates,
If
just
these numbers go up, the other numbers potentially go down.
also one data limitation. So it's relatively complicated to measure actual screening rates just because some of these screenings aren't on an annual frequency cadence. Specifically, colonoscopy screenings start at a relatively late age, and then depending on your risk factor are maybe only every 10 years or 3 if it's Cologuard or FIT test. So this data is a 12-month snapshot, just looking at the most recent 12 months. So it's not comparable. If we actually want to look at the screening rate in your population, like the absolute number of the screening rate, we need to think back to the medical PG discussions with our carriers where they report the HEDIS percentiles. Those are more like 80, 85% for these. And I'll pull those back up so I can make sure to circulate those. What's interesting about these comparisons are where we're looking for these comparisons, and then also within race and ethnicity. is looking between the categories to see if there are gaps we should close. Don't focus so much on the absolute number just because of the timing issue that I mentioned.
Thank you for that.
Okay, if we could go to slide 27, just to wrap up the analytics. There was 5 conditions in the October meeting that we kind of identified as areas that may be worth sort of taking a deeper dive and quantifying and understanding. These are high costs, either on the medical or medical and pharmacy cost. So it's behavioral health, and these are categories, right? So behavioral health, cardiovascular conditions, immunologic infection, and then inflammatory bowel disease. This one, the lower table, takes a look at it in context of race, ethnicity trends, and whether we're getting more diagnosed. So again, these are based on diagnosis data. That doesn't necessarily mean that's the true prevalence. But it's just interesting to see that either because there's no new treatments available and or more direct-to-consumer advertising. So a lot of like the medications for immunologics are what you see on TV. But just to note that there are some prevalence in the top table plus trends year over year showing below for some of these conditions.
So just a quick question. So inflammatory bowel disease, as an example, there are negatives in there. Does that mean negative from the prior year? Is this like from 23, 24 to 24, 25?
24, yes. Inflammatory bowels is small numbers.
Right.
So they may have fallen off plan. Because it's a chronic condition, I would expect them to still have claims previous year versus the last year.
I just want to understand what the negative is. So yeah, okay, good.
So to Kristen's point, it's sort of the general relative, frankly, the number swings are going to be variable depending on the sample size for those. And inflammatory bowel is probably the smallest one there in terms of prevalence.
Yeah, it's the year over year trend from calendar year 24 to calendar year 23, because this clinical data really works better on a calendar year slightly off.
I have a question, and maybe that's for my own advice. It's probably not for this slide, but looking at the OEB benefits and looking at this data, how would our population of OEB members compared to a subgroup that is not part of OEB, for example, the general population? Would we say that the OEB members have a healthier standard or healthier because of the pushes that we have done, or are we falling on average, or like, I don't know, maybe it's a different question for a different time.
That's a tough one because your baseline is different. If we do averages, then you're kind of in the ballpark. But like we're trying to show here is that the prevalence is not uniform across just by the race ethnicity data that we do have is showing variability. Now, some of that we kind of knew from correlations, right? There's some genetic factors to some of these conditions, but others are, again, this is just type level. So is it not getting access, not getting it diagnosed? And to be honest, as a provider community, sometimes we do have intrinsic bias, rightly or wrongly, and we forget or we don't think about it when we're looking at a person of a certain certain race ethnicity, and we miss those diagnoses. That's an issue. So yeah, it's the listing and rank order of these conditions is pretty similar. But beyond that, it's hard for me to say from a benchmarking.
I guess there's my assets because we have been striving to provide or give quality healthcare or access to quality plans for our members. And if I'm a rank and file member or a rail rouser, I'll be like, okay, well, tell me how OEB is better than the general population. Why we have better quality healthcare than someone who doesn't have OEB. Yeah, but that's the reason of my question, not because I don't. So that's all.
Yeah, and having it available because it's part of the plan, let's say preventative service, right? That seems like a low-hanging fruit as a clinician. It's available, it's covered, and the providers are there. But if the utilization is low, then there's a disconnect, right? Then the question is, how do we address that? And those are some of the tactics that may come up in a discussion as part of the strategy. Are the things that we can do to bridge that, because what is available is comparable. What is being achieved clinically and delivered from healthcare is as good, or in some cases, not as good as can be the potential. And I would say cancer screening is one of those areas. There's room for improvement.
In terms, oh, go ahead, Tom.
Question, trying to make sense of the bottom portion of that slide, the table. So just to clarify, these are percentage increases year over year from 23 to 24 of OEB members.
Yes.
And the Black or African American column shows a significant increase largely across all of those conditions. And if I think about health disparities, I'm not sure how to interpret that. Is it that the population of OEB members who identify as Black or African American are less well year over year, or is it that they're accessing more care? Because if they're accessing more care year over year, that means that would be saying, gosh, we're headed the right direction in terms of assuring that Black or African OEB members are getting their healthcare needs met. That's a much different conclusion than they're less well year over year. And so I'm not sure how to make sense of that.
It's the right question to ask. It's the same question that we ask when we talk about risk scores, because when it came up earlier today, we were talking about, or Ian mentioned it, I think at the start of this section. We know about our members because we have claims diagnosis data on them. We have claims diagnosis data on them because they went in for some kind of visit or medical encounter. We don't get diagnosis data on pharmacy claims. Really what we see on medical claims. And we saw on an earlier slide, 96% of our OEB members get some kind of service. It was only 6% that didn't get any kind of service within the year. I would guess maybe even those are out of area dependence, but I'm curious. We'll look into that over the month. But what I think we need to think about it as both things, Tony. So there would not be an increase in patients, even if it is an increase in the diagnosis rate. The only way you have an increase in the diagnosis rate is when you have patients with the diagnosis. So I think in the end, it's telling us the same thing, which is maybe we are expanding access, or our educational materials are helping, and the condition is still prevalent in our community, and that's showing up in our claims data. So it's evidence of all of these things together. I don't think we have to try to separate them, and we can't, transparently, but I don't think we have to try to separate them. There are small numbers in here as well. So if we look up to the top section, those are the number of OEB members who have self-reported. And I know we've taken a deep dive into this earlier this year as well. Those are the number of OEB members who have self-reported into those race and ethnicity groupings, and they can self-report into multiple. And so we've captured exactly how they've self-reported. And then below that, it's the number of those members that have one of those diagnosis codes in the claims data in that year. So for some of these categories, so for cardiovascular health, for some of the race ethnicity groupings, we're talking about 200, 300 people. So a swing of, it's easier to have more trend volatility in a smaller pool of people is my point. So there's a little bit of that. But what we want to see though in this bottom category also is confirmation that we're working on the right things. So are we, and we've talked last month about the prevalence of behavioral health in our community. And even though we're not focusing on behavioral health today, because there are so many other work streams behind the scenes and have been now for years. So behavioral health, we're still seeing in general an increase in patients in with behavioral health care conditions. Right below behavioral health care, we're seeing an increase in patients also with cardiovascular conditions across all race ethnicity categories. So we're using that to say, hey, by focusing on cardiovascular conditions this renewal cycle, we're not leaving anybody out. That also benefits OEB as a whole, and it benefits the different race ethnicity populations as well, from what we can see. So.
On the data for members that are
multiple reporting? Are you have a rank sort, or are you double counting?
Counting.
Double counting.
It's double counting.
Yeah.
So the sum total is higher than the actual total.
Yes.
Yes, but I took a deep dive into that bill in between the first time that you raised that question. I don't know if it was last month or the month before. And it's actually a relatively small number of
Right.
OEB members who have reported multiples. I don't want to invalidate the importance of that. Just wanted to
It's
put it
gonna
in.
grow, in my opinion. Just people are finding out about it.
Rose, can you go to slide 25? And the last comment onto that, Tony, is if we look at the diagnosis prevalence in context, slide 25, yes, with the utilization for the Black and African American, because that was the question. They do have higher utilization of inpatient and ER visits. So a byproduct of knowing more is because they're also using service more, because we capture diagnosis data as a result. So it's not necessarily causality, but there are potentially some correlations. Office visits is higher in patients as well as ER if you go down the column form. So different data points, again, looking at questions individually. The harder one is it because of this? That's okay. Let's proceed to slide 28. So it is with that kind of data that led to the section here, and the discussion that we want to have is around the clinical strategy, right? And slide 29 kind of prioritizes how we define and prioritize strategy. I think there are three elements that have to line up, right? We want to make this an informed decision. So again, I call it clinically based, data-driven approach to how we define the priorities here. It has to be both impactful and achievable. Going back to John's slide, it's like, okay, what's our collective opportunity here to set direction and to influence? That leads to what's achievable, and things that we prioritize hopefully are impactful to the educators and members that we're responsible for. So think about those three dimensions as we proceed. The process is in the next slide, and it's a discussion, and we're using a previous process to kind of outline how this could feel. So in a previous similar retreat discussion, we looked at the topic around cardiometabolic disorder. This is a complicated label because it really is not one single diagnosis. It's a lot of related conditions that if you have one, there's a chance that it leads to the second, comorbidity, et cetera, et cetera. So it is a set of conditions that are all interrelated that we see is high utilization associated with it, and subsequently is impactful to our members in significant volume. So it's just a big prevalence as a set of conditions. So we looked at it and we started to discuss how do we approach a strategy. The last time we focused on this, we assessed some of our point solutions because some of them have been around for a while. We looked at and asked for reports from each of the vendors and started to kind of gauge a couple of dimensions. One is just the level of engagement and usage, given that they've been out there offered by our carrier partners. And then the outcomes. And the outcomes is both a combination of clinical outcomes, that we achieve the clinically meaningful benefit that we would hope. The harder one is the cost benefit, right? Was it worth the effort? And then for some of those observations, we went back and renegotiated and did different things to try to achieve a better cost benefit. So we looked at all these vendors listed here, and some got replaced. Some we went back and kind of renewed an emphasis on to the vendor partners to really kind of up the game, so to speak. And we're hoping to get some reports as part of this renewal process to see how they did since that strategy conversation. Comments on the sort of this three-step approach to figure out what to prioritize in our strategy?
Any questions for
Thoughts? Okay. So next slide, going back to the October meeting, we had identified 5 sort of condition categories that were worth considering. We're kind of suggesting that cardiovascular is worthwhile because it is by total allowed cost. It's right up there as behavioral health. It's a combination of medical, so that's office visits, hospitalization, ER visit related costs primarily. And if you think about cardiovascular, it is going to be the procedures when you have some of those cardiovascular conditions, right? Putting in stents, open heart surgery, et cetera, et cetera. But there is a component of pharmacy. We treat a lot of these conditions with medications, but it's proportionally a smaller percentage of the cost there. The other conditions, the distribution of costs between medical versus pharmacy are as shown here. What's interesting to note is the immunologics and the inflammatory bowel disease, it is predominantly the cost is being driven by the what we call specialty medications, meaning they're very technical medications. They work on the immune system, and they're the ones that are on TV. But they're also disproportionately high cost. So it's a few individuals with these conditions utilizing very expensive medications that get to these numbers. So when we look at these 5 conditions, there's already strategy and efforts addressing behavioral health. It seemed like the next logical condition category to kind of spend some time discussing further is cardiovascular.
And Ian, just a point of clarification, and I'm Sarah, I'm the pharmacy team member. The numbers here for allowed pharmacy they're not offset by the amount of rebates that come back from the manufacturers. We don't have a way to attribute the rebates to specific therapeutic categories, but as a ballpark, anywhere between 20 and 40% of the value you see here for the immunologic or the inflammatory bowel disease probably is.
I have a question. So just follow me because this will make sense in a minute. Okay. I feel like you had mentioned something about dental hygienists in the pandemic leaving. Okay. Is that resolved to some degree? Okay. Another thing, Willamette Dental really struggled with having, adequate staffing to be able to, meet patient needs for preventative service. Okay, I'm gonna get there, okay? This connects. My question is that along with this cardiovascular health, are we pulling in like education around oral health, which directly impacts cardiovascular health? And offering some education around that and making sure that we're also paying attention to like, are our dental providers being able to keep up with care? Are they also educating that, your oral health does directly impact your cardiovascular health, right? Like if you have infections in your teeth that go untreated, it affects your blood, it affects your heart, it can affect your brain, it can affect so many parts of your system. And just kind of like looking at it holistically, like, we can focus on, I'm not opposed to focusing on cardiovascular health, but and making sure that we're like pulling in all of the contributing factors and educating around that as well. And I bring up the dental because, I'm still hearing, issues with members under Willamette Dental not being able to get those preventative visits and those cleanings and those kinds of sorts of things. And so we know when one fails, right, it can affect other things. And so I just want to make sure like we're making that we're looking at all of those pieces and yeah.
Yeah, clinically, we know there's a closed loop between dental care and certain conditions. We do have some providers that because of their organization and integration are better at that. Basically, if they see something, they're making a warm referral or transfer to connect the dots, right? So if they're seeing something on the dental, it's like, hey, this may be because you have this cardiometabolic condition, diabetes or something.
Yeah.
And the reverse is also true. And for other provider groups, it's because they're silos. I think it's harder,
Yeah.
although it seems clinically like a great opportunity to do that integration better. So I think it's come up. It's just different providers have different ability, different structure, process, as well as incentives to do that.
Yeah, I mean, like I just in this conversation, like a concern is, you have a member that can't get into their dental office for months and they don't really know, or something's going on and they're on a heart medication that they're on and potentially it's this that is the cause, right? So like you're band-aiding a situation, right? And so we're just, plugging in holes in a sinking ship and, in that specific situation, right? Like if they can't get the access to care to treat the underlying condition, right? Then the cardiovascular care is like maintaining something, but not treating the root cause of the problem. So just one little piece in what I know is a big grand scheme of, all contributing factors, but something I want to keep at the forefront of in this approach.
Yeah, without access, all bets are off because
Yeah.
we don't know what we don't know.
I was just going to say that we'll look at access for the dental in a little bit, or the flip side of it. We did that as part of the cost immunization on the dental piece. But you've actually scooped my afternoon thing because one of the things you've already hit upon one of the key things, which is, why is it important that people go in and see the dentist? It's because of, things like the connection that you were alluding to between cardiovascular and good dental care. And I think, and again, I'm not the expert here, but the thing is, my understanding of that dynamic is essentially if you have gum disease, it can get into your blood and cause cardiovascular conditions, from arthritic arteries, coronary artery disease, and, even stroke. So I think that's what you're alluding to. And the thing is that, I think that you'll see why that as part of, and Kirsten earlier was talking about how we use the renewal letter as a tool. And that's one of the things you'll see in the afternoon, how we're going to use that tool to really start probing around the dental access, especially to, receiving cleanings and things like that.
Okay. Thank you.
Maybe a couple other work streams, Sally, just to mention that are ongoing related to this issue. So the renewal letter, currently we already have draft questions around medical dental integration. We'll find those in the afternoon when John talks about dental access. It's also been proposed that we'll deep dive into dental access in the summer in our scales. And also we have measures around dental access and we're currently revisiting those to see if they should be tweaked at all for the dental PGs within the carrier contract. And then MODA has a benefit called oral health, total health. Which for certain medical conditions expands your dental benefits. I'll refresh my memory on if that covers cardiovascular conditions and how. And then Kaiser also has a program where if you're in the dental office, they screen for medical conditions or vice versa. So we'll add to our list of takeaways to seeing where cardiovascular conditions fit into those two existing programs. One of our themes Ian is going to touch on for this upcoming renewal is using things that we have in place better and making more and better use of them. So this fits right in with that too.
That the MODA, if you have certain conditions, expands your dental care. Is that only if you also have Delta Dental, or is that no matter what dental plan you have? Because now your medical insurance is covering part of that dental visit.
I believe that's a dental. That's a Delta Dental.
Delta Dental specifically, yeah. And we've talked like just within the Joint Benefits Committee of we offer Delta Dental and Willamette Dental of potentially bringing on Kaiser because of that like integrated care within that Kaiser system. But the issue is that, they're both kind of co-pay plans. Kaiser Dental is more expensive than Willamette Dental, has a max benefit and still has like 1 in a quarter dentist. And so it doesn't like make sense to add something that we're just adding another thing where access might be an issue for our members, right? But I do like that kind of model. But you know, my biggest concern is the members that need that copay structure for affordability reasons, being able to actually utilize those benefits in a meaningful way, you know, or just at all, right? So anyway, that's totally off the, I went on a little tangent. Yeah.
For the purpose of the clinical strategies, here you're talking about cardiovascular, but on the previous one, you talked about cardio. Metabolic. I'm a little confused. Maybe just help me talk a little bit about why we're using the two different terms.
So the last slide, previous slide was a recap of our strategy discussion and priorities related to cardiometabolic conditions. So that's sort of the. for
In
lack of
prior
better-
years.
Yes, in prior years, with the big umbrella.
Okay.
Within that included type 2 diabetes, obesity, hypertension, hyperlipidemia. What those conditions can lead to and add to is the cardiovascular diseases.
This is more of a subset
Yes.
of that.
So I would think about cardiovascular diseases as conditions involving the blood vessel and heart muscles. And we can go to the next slide, Rose.
Thank you.
And very valid point. It's because these are all interrelated, but we're kind of chunking it and taking it sort of layer by layer. And why on cardiovascular condition, which is a category, I acknowledge that, we listed the 5 conditions that are underneath cardiovascular that seem to be the primary contributor of cost and prevalence in the population. So in other words, these 5 conditions seem to be the ones that are worth sort of a further understanding and drill down. They are a subset of a table that I added here. By mortality, heart disease is still your number 1, right? It's still higher than cancer. We're doing better with cancer mortality, which makes the heart disease the number 1. Just to note, and what was curious, and I left it in, is we don't talk about it as much, even though it's the number 1 cause of death. We talk about other contributors of mortality in lay press. So I thought that was interesting how if there's a disconnect. But I didn't want people to notice the significance of it.
That's really cool data.
This is data heavy. I'm sorry about that. So the top 5 conditions, I'll just kind of run through. The first one is basically arrhythmias. So you'll know like heart block or atrial fibrillation, right? Now the Apple Watch can detect atrial fibrillation. Cardiomyopathy are abnormalities involving the heart muscle, either loss of heart muscles or hypertrophy or too much enlargement of the heart. Cerebral vascular disease, think of blockage of the blood vessels of the brain, right? The strokes, transient ischemic attack. Coronary artery disease is the blockage or problems with the blood vessels of the heart. So those are your 2 sort of common conditions. And then there's hypertension. What's also important to note is if you recall the cost slide that I showed previously, these conditions, a big component of the treatment is tied to medications now, right? So even though the majority of the cost was attributable to medical, ER visits, procedures, hospitalization, medications was relatively low. It's because we have a lot of medications here that are useful and effective, and many are generic now. So that's the opportunity, and that's why we thought this was one worth discussing and putting on the table. Okay, let me wrap up real quick.
We'll pick this up after.
Pressure.
Good point. So let's go ahead with lunch. It's already outside, so go ahead and grab your lunch and come on back here for our regulatory roundtable, which will take us for the next.
Andrea.
Oh, Dr. I have a question.
Yes.
So it's more just a note, because language really matters when we talk about equity. And I think early we can see equity as an active process, which was powerful. When I read that, But later, I can notice that we're gonna shift to the terms like achievable, impactful, which are important, of course, but also they don't explicitly reflect the same equity focus. So I just wanna mention that we need to keep the language consistent. So it's gonna help for us to commit specifically for equity. It's gonna be our center for how we're gonna measure our success. Thank you.
We'll have a working lunch, is that correct?
Yeah. And Wade Simons joined us. Thanks, Wade. So he'll be leading our regulatory discussion over lunch.
Okay, and when you said outside, that means you go past the desks in the front and in the hallway, there are 2 rooms, 137 B and C, and that's where the food's set up.
We'll come back once we get our lunch.
Well, I will mute and then I'll turn it back on when it's back here with the.
Yeah.
So everyone,
Oh, wow.
we have some entertainment, I should say, for during lunch. And we're fortunate to have